All right. Should we get started, guys? Are we waiting for anybody else? Okay. So before I continue, we're going to talk about GFR today. Any question with acid base that we discussed yesterday, or hypo and hypernatremia? I know it's still a lot of concept, but anything that you got stuck? No? All right. So let's talk about GFR now. So the main reason people come and see me as a nephrologist is because somebody told them that their kidneys are not working well. And how do we know, or any physician knows, that their kidneys are not working well? How do we know that? I mean, the patients ask us, and doc, how would you check my kidneys? And what is GFR? I like it a lot. But what does it stand for? GFR. Very good. And how do we check that? Anybody who does any test, I know immediately what happens to their kidney function because it's one of those standard tests in everybody. Well, no, don't get too fancy now, but before GFR is anything else that we look. And GFR is typically based on that. It's a calculation, as you said. Very good. Excellent. So whenever you guys do any type of labs, one of the things you see after CBC is sodium, potassium, chloride, bicarb, and then BUN and creatinine. And creatinine is the one that we follow to see what the kidney function is doing. And what is a creatinine? And why is it being used as a measure for kidney function? I'm going to give you some concept in advance so then we can go faster. What is very good is a product of muscle. And what's the reason we are choosing creatinine as a measurement for serum creatinine as a measurement for kidney function? And the reason is ideally we are looking for something that pass through the kidney, right? Yeah, get passed through and doesn't get reabsorbed and doesn't get secreted down the road after filtration. Makes sense or no? If something passes through the glomerular and doesn't get secreted or absorbed, and you measure the amount in the blood and the urine would be more or less the same, that would be an ideal biomarker for your kidney function because it filters, nothing happens. Creatinine is not that. Actually, it does get secreted. But more or less, for many, many decades, we are using it as a way of measuring GFR or glomerular filtration. So I'm just going to tell you how does it get measured, but what is the normal GFR is about 120 ml per minute. And I tell you how that we come to that numbers. But if you think about it, about 180 liter of plasma, or about 35, more than 35 times of your total blood volume passes through the kidney. Imagine that's huge amount of volume blood that passes through the kidney and gets filtered every day. And that's why when you have problem with the kidney, we need dialysis because this is huge amount of work that needs to be done. Okay. I'm not going to talk about, so basically, what is the filtration of the kidney? I hope that most of you guys know by now. We have efferent arterial, you have the glomerulus and proximal tubule that pass through that. Any question about that? This is like the main concept that you guys should know by now. So what is the filtration pressure? As you can see, for things to get filtered, you need a filtration pressure on top, which is really a Starling pressure. This is hydrostatic pressure that goes through the kidney in the filter. You have some, do I put it here, or osmotic pressure against that. So hydrostatic pressure, that's like an oncotic pressure that goes against that. And then at the end, you get the filtrate that passes through the kidney. So here I put some numbers. Net filtration pressure. I saw that sometimes they ask about it. So the main pressure is the hydrostatic pressure on top is about 55, and then you have oncotic pressure about 45 against that. So the net pressure that goes through the kidney about 10 millimeter mercury. Okay, more and less some numbers to remember. Nothing, I don't think they're going to ask you a specific numbers, but to know, well, how does the kidney filtrate? The filtration is through adjustment of the hydrostatic pressure, sometimes oncotic pressure, but mainly is through the hydrostatic pressure that goes through the kidney. That's the way the kidney adjusts the filtration. And how does it get filtered? It has to pass through three different layers. So here is the blood, goes to glomerular endothelial cells, then passes through basement membrane, and at the end it passes through a specialized epithelial cell called podocyte. So the filtrate, the hydrostatic pressure should be enough for everything to pass through that. Not everything passes through, right? It has to pass through endothelial cell, basement membrane, and a specialized cell called podocyte with a slit diaphragm at the end. What are the things that should not pass through the kidney? If you see that, that's abnormal. Very good. Protein. If somebody has protein, a lot of protein in the urine, mean that there is something wrong either with glomerular cell, endothelial cell, basement membrane, or podocyte, because these are too big and negatively charged. And endothelial cells are also negatively charged. So things, proteins and albumin, that's the way we look at whether somebody has kidney problems or not. If glomeruli are working well, you shouldn't see too much of albumin in the urine. And we talk about nephrotic syndrome and nephritic syndrome tomorrow, things that should not pass through the kidney, and they do pass. And depending on what you see, you have a specific diagnosis for kidney problem. Leukocyte, they are small enough to pass through it, but the amount should be very, very small. Now, there are some bigger leukocytes that should not be passing through. So if you have leukocyte in the urine, what do you get really? What's the reason to have white cells in the urine? What is it? Necrosis? No. I think there's somebody they're gonna talk about it today. When you have white cells in the urine, it's because mostly you have UTI, trachea infection in the urine. Yeah, you shouldn't see more than one really passing through the kidney. Okay, so as I just said, endothelial cells are negatively charged. So you can see that if you put sugar, anionic sugar, they should not pass through the kidney as much. If they are positively charged, you have more. And if they are neutral, you have somewhere in the middle. Okay, and this is how we came with about the number I just mentioned. We have about 600 ml of blood per minute that reaches to the kidney. About 20% it gets filtered, which is about 120 ml per minute. That's the way we have the 120 ml per minute of the filtration. If considering that there is 1400, 1440 minutes per day, this must be multiplication, not divided. This is about 173 liters per day that passes through the kidney. Make sense? All right. So this is huge amount. We get about 1% in the urine, about 1 to 2 liters. So 99% of whatever goes through the kidney, and imagine 99% of passes through the kidney get reabsorbed. So imagine like what are the things that you really need to do so much work? You need very good mitochondria. Your mitochondria is generating ATP for you. They really should be working very well in order to so much work for the kidneys to be accomplished every day. The other thing I forgot to talk to you about, I've been to many different countries and more and less, I think most countries, they teach hyponatremia, hypokalemia, all of those things, more or less the same way than here and in the States. But what's really different, and I hope that some of you guys would be doing this, would be really to do research in medicine. Now, you guys may say, well, I don't want to do research. I barely am making it to medical. That's not the case at all. Okay, it's the way you guys are learning here. I think this is as good as anywhere else in US and in Canada. So just remember, once you get into medical school and you finish medical school, you get into residency and fellowship. One of the things can distinguish all of you guys from the rest of people who come from China, India, Pakistan, Iran, all of the other countries, if you're interested in research. That really distinguish you guys from the rest of people because first of all, then you learn a lot more when you're doing research. This is just by definition. But also, if you want to be chief of department of anesthesiology, pediatrics, whatever you guys have in mind, they want you, you need to do some research background. And some of you guys already have some research background, so use it. Clinical research, basic science research is something interesting. Now you guys, well, all of those things are complicated. But once you guys start practicing medicine, you guys, so many things, same day, so many patients that after a while, it just you don't think anymore. You already know what you want to do, and that's the time it gets a little bit boring unless you do some research. When you do research, you get this immediate as well as delayed satisfaction. You get immediate satisfaction by seeing patients, but also research, which is kind of like more delayed satisfaction. It is a wonderful life. You guys should really think about research down the road. So we just talked about other things and going back to our kidneys and nephrons. Okay, let me just, okay. So how do we measure GFR? So nowadays it's different. When you look at creatinine, most of the time GFR is already measured and they give you a number. Okay. The normal in reality is not 120, it's about 100. So anything below 100, I think is abnormal. But let's say, how do we, for your board exam, they may ask you to understand some concepts. Or one concept is that when you look at the concentration, okay, any kind, let's say you're looking at the creatinine here. The concentration of creatinine in the urine, just X, imagine is creatinine. The concentration of creatinine in the urine times volume of the urine here. Okay, concentration of, if I measure concentration of creatinine here, times, let's say, the amount of urine here, should be equal to concentration of creatinine in plasma up there, right? And then the filtration rate, how much it passes through. Make sense? Now, this filtration rate, here I put it here as clearance. So clearance of creatinine, which is also known as GFR, clearance of creatinine is really dependent on if I measure the urine concentration of creatinine, if I know how much urine somebody has, the volume of the urine, and what is the concentration of creatinine up there, I can measure the clearance or GFR of creatinine, right? Huh? All right. So that's the only thing you guys have to learn. Any substance, you measure the concentration of that substance in the urine, the total amount of urine, you divide it by the concentration of that in the blood, you have the clearance of that substance. If it's creatinine, it's called GFR. The clearance of creatinine for practical purposes is called GFR. All right. So here I made an example. So let's say it's just question of make sure you know the units. So let's say urine creatinine is about 120 milligram per deciliter. Urine volume is 1440 ml over 24 hours. And serum creatinine is 1.2. So you get every number you need to have to measure the clearance of creatinine or GFR. You just have to make sure that the urine volume is ml per minute. And because just intentionally I put 1440, you divide it by 1440 and you have 1 ml per minute of urine. So then your creatinine clearance is 120, which is the concentration in the urine, times 1, the urine volume, which is ml per minute, divided by 1.2. Your GFR or creatinine clearance is 100 ml. Make sense? That's just to make sure your units are correct. All right. As I said, creatinine, we use it historically, but it's not an ideal way of measuring glomerular filtration rate. Because in really to measure that, you have to have something that does not get reabsorbed or secreted here. So your urine concentration here would be the same more or less as plasma concentration. So then you can really measure the filtration rate. And creatinine does get secreted. So for not practical purposes, for research purposes, we use inulin. Inulin does not get reabsorbed, does not get secreted. If you inject inulin to a patient, you measure the concentration of inulin in the urine, the volume of the urine, and you divide it by plasma concentration of inulin, you get a very exact measurement of GFR. And GFR, as I said, is the clearance of inulin in this type, or creatinine for practical purposes. All right, let's take a look at this formula and make sure we understand this GFR, which is creatinine, which is inulin clearance here. Any question? All right. So there are other ways of measuring accurately the GFR, and that happens if you have a cancer patient, for instance. You want to give them chemo, and the amount of chemo has to be very exact depending on GFR of the patient. You can use different way, technetium-99, iotalamate, or EDTA. You inject them, and then you look at the amount that it stays in the body. And there are ways to indirectly measure the creatine clearance. I'm not going to talk about it today. The other way is to look at cystatin C, the same thing as creatinine nowadays. People can measure cystatin C clearance, the same thing, urine, amount of urine of cysteine in the body times volume of the urine divided by plasma concentration of cystatin C, and you get a clearance. It sometimes is more accurate, sometimes not. And then most of the time, you get some numbers already. You don't measure it. Go ahead. I think sometimes is, but because it gets influenced by inflammation, and many of our people are sick and they are inflamed, it does changes with inflammation. So many times you get both. You get the creatine clearance and cystatin C clearance and see whether they correlate with each other. Both have their own pros and cons. Okay, so there is some formulas. You don't have to memorize any of those things. It's already in when you order labs, it comes with the result. They're not going to ask you any of those things. The only thing that traditionally, at least when I was a resident, we had to learn, I don't think you guys have to learn, is the Cockcroft-Gault equation. You can measure indirectly the creatine clearance even without knowing anything about the urine. And this is 140 minus age of the patient times weight. If they are female, you have to multiply by 0.85. You divide it by 72 times serum creatinine. More or less, it gives you some numbers for your GFR or creatinine clearance. You don't know anything about you have not measured the urine creatinine in this patient. You don't know how much they are urinating, but you just have the serum creatinine number because that comes with every lab. Based on that, you can more or less measure GFR. We don't do it anymore because automatically, when you order tests, GFR is calculated and it gives you the numbers. Okay, so for me, I put here a number, let's say a 50-year-old, 140 minus 50 times 70 divided by the weight was 70 divided by 72 and creatinine 1.2. Okay, a 50-year-old guy, 70 kilo weight, serum creatinine 1.2. You can measure the creatinine clearance. All right. There are other ways to measure that. I'm not going to spend time with that. One thing that you see it all the time is the different types of CKD. This is very common now. There's a stage 1, 2, 3, 4, depending on GFR. If your GFR is more than 90, is a stage 1, which is like normal. If it's less than 90, but more than 60 is a stage 2. More than 30, but less than 60 is stage 3. More than 15, less than 30 is stage 4. Or less than 15 when you need dialysis. So stage 2 and 3 are very common. Many people, they have a stage 2 and 3 kidney disease. And these are people that they get targeted for treatment in kidney diseases, or they don't have kidney function at all, they get on dialysis. So stage 2, 60 to 89, stage 3, 30 to 59, or 30 to 60, basically. Okay? All right. So the last part of it is the scientific part of it. Well, how does GFR gets regulated? How does the body increases or decreases GFR depending on what's happening in the body, right? And I just told you before, the main way is through afferent or efferent arterioles. But how does that happen? Okay, we have two specialized cells here, one called macula densa in the proximal tubular cells, and then we have JJ cells here that they secrete renin. Okay, so macula densa and renin. So like everything in body, you need something to sense, and then you secrete something in response to what you're sensing. And the macula densa here, it senses changes in the sodium chloride that passes through this. Kind of like osmolality, yeah? Like the amount of sodium chloride that passes through that proximal tubule, macula densa senses that and adjusts the GFR by secreting the renin in these granules that you see. And what does the renin do? What does renin, angiotensin, aldosterone system, which is a very important system, not you. What do? They kind of vasoconstrict or vasodilate arterioles, either afferent arterioles or efferent arterioles. Okay, that's just the way it's because think about it. If it this gets constricted or vasodilated, the amount of filtration changes, right? Just this the way, and the same way here. If this constricted or dilated, whatever comes through that, it also changes. So actually, this is efferent arterioles. So if this constricts, what will happen to your GFR? It could increase depending on what how much constriction we are talking about. But most of the time, it increases the amount of GFR. Okay, so renin-angiotensin system, you guys probably heard that before, but we have angiotensinogen from liver gets converted to angiotensin 1 through activation of renin. Okay, and then angiotensin 1 converted to angiotensin 2. It works on different vessels as well as it works on aldosterone that we talked about that yesterday. A very complicated system. That's the macula densa regulation, okay, through renin and angiotensin system. So at the end, angiotensin, what it does, it constricts efferent arterioles. Efferent arterioles, and that stays, this is the one. And that's very important in terms of adjusting GFR. The second mechanism is tubuloglomerular feedback. Basically, is a direct mechanism that is worked through macula densa directly works on the afferent arterioles. Direct effect, not through renin, but the direct effect when they have low sodium chloride here or high sodium chloride here. And they work by adjusting the amount of afferent arteriole to adjust for the GFR. Okay? So for instance, I put here when sodium chloride is low, when sodium chloride is that this macula densa, they send signal to these cells to dilate the afferent arterioles. Okay, so if you dilate the arterioles here, the afferent arterioles, you have more blood flow and GFR, and vice versa. There is also myogenic autoregulation. That's also through afferent arterioles that they can dilate it or they can get constricted dependent on the myogenic, the effect on the vessels itself. That's an inherent effect on the vessels in the arteriole. They can get constricted or not, and they can restrict or increase the amount of uh, clearance through the kidney. And sympathetic nervous system also. I think I got this from one of those online explanations of GFR and low blood pressure and the effect on afferent arterioles as well. But this is also a way of vasoconstricting afferent arterioles and reducing GFR. So if you vasoconstrict afferent arteriole, you have less GFR and vice versa. Okay. And the last part of it, so I told you guys how to measure clearance of any substance, right? Clearance of any substance is easy to understand. But how about one other concept? They ask you to measure fractional excretion of any substance, which is usually they ask you to look at fractional excretion of sodium, potassium, things like that. It's the same concept, and I show you how to measure that. All right. So here, if you look at it, it's the same concept, which would be fractional excretion, the amount that gets secreted through the glomerular, the amount that gets secreted through the glomerular, let's say sodium here, depends on the amount of that, let's say sodium in the urine the amount of sodium in the plasma divided by something that you kind of like adjust for the filtration in the kidney, which we use creatinine. So if you use sodium here, creatinine, and creatinine always the bottom line, you get the fractional excretion of everything you want to decide to measure, and you multiply by 100. So let's say, and the reason here, this is the same concentration of sodium in the urine times volume is the same that concentration of the sodium in the plasma times GFR, right? It's the same concept. So if you make it the other way, you get like excreted solute by filtered solute, would be the same concept. This is the way that you have to learn at the end. Whatever substance you have, you measure it in the urine and plasma, and you divide it by the creatinine measurement in the urine and plasma. You standardize it basically based on GFR. You use creatinine to standardize for GFR. Okay? So you can use here magnesium, calcium, potassium, any, and how does excretion of potassium helps you? Or let's say you're measuring fractional excretion of sodium. How does that help you? Why is it important to measure that? Because let's say if you're hypovolemic, and that goes back to hyponatremia. If you're hypovolemic, right, what do you expect the kidneys do for you in terms of sodium? You want to reabsorb sodium and water with it, you know? So when you measure the fractional excretion of sodium, we should really measure what's going on in the urine. That should be very, very low. You don't want to see a lot of sodium in the urine, right? Because you expect the kidneys to reabsorb all the sodium and water for you. But if you don't see it, right, that means there is something wrong with the kidney. If you do see it, that means that the patient is hypovolemic. They have very, very small amount of sodium in the urine. They're trying to reabsorb all the sodium before getting dumping out of the kidney. Make sense? All right, guys. Questions? I'm gonna stop here. All right, that's it, guys. Good luck with you guys. Tomorrow we're gonna be talking about nephrotic syndrome and nephritic syndrome. On Thursday, I have to attend an NIH meeting, but Friday or even Thursday later during the day, we can get together and talk about anything you want, anything related to kidney problems, obviously. And we can go over some of the concept that you didn't understand it, or if you thought you did understand, but you went and you get confused by reading a paper, we can go over what does it mean. Kidney problems usually are kind of intellectual problem. You really have to think about it's not a mechanistic problem. It's not like plumbing in the heart that is more sometimes easier to understand. You really have to think, well, what does hypovolemia, hypervolemia, and hyponatremia, what does it mean really before coming with the treatment? With that, I'm going to stop and good luck with you guys. And I'll be more than happy to answer any questions. Thanks.